Allison Piscolini. I'm the director of the Athena Breast Health Network and the Wisdom Study. And this is our monthly community forum for the Wisdom Study. It is the monthly community forum for March of 2023. And today we'll be talking about breast density, as well as other breast cancer risk factors, but mostly on breast density. As we know, you've probably seen a lot of news about what it means and what the new requirements are to report breast density back. So would love to help to answer any of your questions and also tell you a little bit more about breast density as well as other risk factors. So if you haven't yet, if you could please introduce yourself in the chat, and we would love to see who is here and go from there. So hopefully this is still recording. It looks like it is. So the format for today is that, again, we'd love to hear your questions. Please feel free to ask those questions in the chat or to raise your hand. We'll also, pause at certain points. Feel free to sort of unmute and ask those questions. We do ask if you are not speaking, if you could keep yourself muted. We know there's background noise a lot of the time, so we'd like to just make sure that everyone can hear. This will be shared on our Wisdom website. If you missed any portions or if you want to share it with anyone else, please feel free to. And then we'll have a short survey at the end for you to give some feedback. So why are we here? We started these Wisdom community forums about almost a year and a half ago, really with the goal of bringing the community together and being able to provide some additional information about breast health, particularly topics that are ones that you've suggested that you'd like to hear about. And our whole goal and our whole mission here is to help to move together as a community toward equity and better outcomes in breast cancer for everyone. So breast cancer is a multifaceted disease, but also there's a lot of components when it comes to screening. And our goal here really is to bring everyone together and to provide more information and to talk through some of the components that go into this big field. We know that it's not a perfect science and that we need to make improvements. That's why we're doing the Wisdom Study. We know that breast cancer is not one disease. Sometimes it can be really, really aggressive where screening really doesn't help. Other times it can be very slow growing or indolent. And we want to make sure that we're screening based on someone's individual risk of those different breast cancers, not just having a one-size-fits-all approach. We know that younger women are at risk for more aggressive cancer. We know that family history, which is usually the risk factor that's mentioned most often, is really only one piece of the puzzle. And we've had some learnings in the Wisdom Study that not everyone who has a genetic mutation even has a family history. In fact, the majority of people with a genetic mutation do not have a first-degree family member with breast cancer. So there's a lot that we still have to learn. And we are on a mission here at the Wisdom Study to help to fill in those gaps and really find a better approach to breast cancer screening and prevention. We also know that breast cancer is worse for some communities, and we want to make sure we're tackling that as well. We've had a whole year plus of forums that can all be found on our Wisdom website. We'd invite you to take a look and a listen to those if you're interested. Last month, we talked about breast cancer in the Black community. And in January, we talked about nutrition and breast cancer. So we'll send the link out, but also know that these are all topics that we can discuss again. We know these are ever changing. And if there are topics you want to hear about again, please let us know. We can include those in some upcoming forums as well. Just a quick shout out. There are a few different celebrations this month. There are always lots of months and milestones to celebrate, but in particular, March is Women's History Month, which I think we are all here at the Wisdom Study and in our Wisdom community making history together in trying to improve breast cancer screening. So just want to take a pause and thank everyone for being here and being part of our mission. It does take everyone to be part of the solution and to try and ask questions that will help to improve the way in which we're approaching breast cancer screening and not just doing what we've been doing for the last 30 years. It's also National Nutrition Month. And as I mentioned, January, we had a great forum with cancer nutritionists. So I invite you to check that out. And it's also colorectal cancer screening or awareness month. So lots of campaigns and awareness around colorectal cancer screening this month as well. All right. So without further ado, Laura Esserman, who is the lead of the Wisdom study and also the I-SPY trials, and she runs the breast care center at UCSF, will be talking to us today a little bit about breast density, what it is, what it means, also some information about what has recently come out from the FDA about reporting back breast density and what that might mean for you.
Okay, so, we've talked about this before. I think the whole reason we started the Wisdom study is because everybody has there are a number of factors that determine your risk. Your family history, and probably underlying the family history for many women are their genetics. It's not always, because we don't know everything yet. That's what we can measure. Breast density, we know that if you have the highest density relative to the lower, and it's basically put into 4 categories. So if you have breast density comes as 4 categories: fatty, scattered densities, what the term heterogeneously densely mean, it's pretty dense, or very dense, where like everything's kind of very dense. So that's A, 1, 2, 3, 4, A, B, C, D, those 4 categories. And there's a different distribution. It actually turns out that half of women have dense breast tissue and half don't. And you'd think, well, that has to do with whether you've gone through menopause or not, but it doesn't always, so that sometimes your breast density goes down and sometimes it doesn't. And that probably is partly inherited. And we'll get into a little bit of the science of that and trying to understand so that we can do a little bit more than just record it. So what does it mean? It doesn't mean that if you have dense breast tissue, for sure you're going to get breast cancer, nor does it mean that if you don't have dense breast tissue, that you won't get cancer. It means it's one of the things that contributes to your risk. And if you're the highest relative to the lowest, that actually there's a big difference. It's like 4 times higher, but that depends where you start. Age has been something that we have always used as a way. As you get older, your chance of getting breast cancer is higher. However, if you've had an inherited mutation, your risk is actually when you're younger. And there's certain tumor types. It's like when you're younger. Triple negative disease is more common in women who are younger. That doesn't mean you can't get it at any age. It just means these are things that we have observed. If you have atypia or lobular carcinoma in situ, these are actually risk factors. I think actually DCIS, or in situ, but not invasive cancer of the breast, is actually a risk factor as well. So the more sedentary you are, as for most things, the higher risk you are. And so being very active makes a difference. How old you are when you have your children, or if you have children, not having children does increase your risk. Probably has to do with how often your gland is stimulated to develop and then involute or sort of change, and where the milk dicks kind of come out, the factory is open and then the factory shuts down. So how that's done, there's a lot of interesting developments on that as an opportunity for prevention. Breastfeeding is usually protective, but again, if you breastfeed, that's not a guarantee that you'll never get it. And if you don't, that's not a guarantee that you'll already get that, get it. So now, prior hormone therapy, this relates largely to hormone replacement therapy. And this has been hugely controversial over the years. And it used to be that Prempro, this combination of Premarin and progesterone, estrogen and progesterone, used to be the fastest or most commonly prescribed drug and the highest grossing drug in the country, until the Women's Health Initiative study showed that many of the claims that were made by the company were actually not true. Like that it prevented Alzheimer's disease and prevented heart disease and prevented breast cancer, which in fact it doesn't. It's the combination with progesterone that makes it risky. So that's sort of where we were. So, we actually don't recommend that everyone necessarily start hormone replacement therapy, but if you need to take it for a small, if you have like terrible hot flashes, it may be reasonable for you to take endocrine therapy or hormone therapy for a short period of time. There's no absolutes here. We can talk about that also. And there are some sort of combination therapies that may turn out to be very useful or very important for some of those people who are really struggling over symptoms of menopause. And, we're working on prevention tools and new combination agents. So that's something we can talk about a little bit. Okay, next slide. So again, what is it? It's just a measure of how much of your breast tissue is fatty tissue. And there's different components of that. Glandular tissue, that's the glands that actually turn into your milk factory, and the fibrous tissue is the tissue in between. One nice thing about dense breast tissues, makes your breasts very perky, and if you have very fatty tissue, there's usually, that's where gravity can take over more. And it's surprising, but it's not really related to breast size or firmness, although you can tell sometimes. You can tell the difference between someone who's got very fatty tissue versus someone who's got very dense breast tissue. And we talked about the risk. And so I think it's important to say that when you think about breast density, having 50% of your population with dense breast tissue, that's not an abnormal condition. That's just so. It turns out that only 10% really have that very high density. And that's really where mammography doesn't work as well. So this idea of trying to reduce your breast density, because it might also lower your risk, but also improve your ability to get screened, is actually important. So part of what can happen is sometimes if you have very dense breast tissue, it can hide an underlying small cancer that you might not see, or that you might miss. Okay, next slide. So here are these 4 categories. This is the fat on the left here. Yeah, there you go. Thanks, Allison. Where Carol Merrill is pointing. Can't remember the name of the show. Anyway, Let's Make a Deal. Yeah. So there, that's mostly fatty. You see it all kind of looks blackish or whatever. And then here in the second is what we call BI-RADS B. So that is scattered fibroglandular density. So a few little chunky things. And here, even at the third one, so that is heterogeneously dense, you can easily see through it. It's not that it's really obscuring it. So that again is 3/4 of whoever has dense breast tissue has this kind, whereas only about 10% total women have this very dense breast tissue, where you can see it might be very hard if there's a small lesion that also leaves. This really dense tissue can, obscure a mass underneath. Is that clear? Any questions about that? So, what the FDA is now recommending is that anyone who has so-called dense breast tissue is told that they have dense breast tissue, but you can see the difference between this category C and category D is very different. And in category D, that's where the mammography might not be as sensitive, but not so in C. So a lot of people say, oh, well, if I have dense breast tissue, I shouldn't get a mammogram. But that's actually not true, because you can see cancers because of a footprint of calcifications that are left, and those almost always show through dense breast tissue. So there's still value, and mammography is still the best idea for how to track whether or not you've got the presence of a mass. And then another thing that's important is that whether or not you should get adjunct screening depends really on what other risk factors you have. If the only risk factor you have is dense breast tissue, maybe you don't need to have high risk screening. But if you actually have a number of risk factors, your family history, maybe you've inherited a mutation, these are things, then maybe what you should be doing is getting screened every 6 months, and with MRI as your alternative. There are a lot of people who think that ultrasound is a great screening tool to be used, and we do it a lot, partly because we don't have other tools, but it's actually not a great alternative. And one of the reasons for that is that ultrasound and mammograms interrogate tissue in the same way. From an X-ray machine, you're sending out X-ray beams. And if something's very dense, it'll block the tissue, the beam from getting through, and it'll flash back and see white. So that's where you see white. Whereas you can see on this one way over here on the left in A, those X-ray beams are going right through and it just looks very dark. A screening ultrasound also is a waveform, and it's sending a wave out. And if you hit dense breast tissue, it comes back as being very dense. So it's often hard to see things. And one of the reasons why we don't love using ultrasound as a screening tool is because it has a very high false positive rate. What does that mean? It means it often finds a bunch of things, most of which turn out not to be anything. And it's really scary for women if they go in and somebody sees something and then they recommend a biopsy. People get very panicked and it's very anxiety provoking. So we'd like to have better tools. So those better tools are, if you are at high risk, you're better off with a tool that looks at things differently, a contrast-based exam. MRI looks by looking at your breast tissue, and you get an IV injection of this inert material called gadolinium that's taken up and washes out of the body within like 12 hours. But it's taken up by the blood vessels, so it's a completely different way of looking at the breast tissue. So you're getting that contrast materials taken up and washed out. And so that rate of how much is taken up and how it washes out through the vessels or your blood vessels tells us about whether or not there's an underlying cancer. An MRI turns out to be very sensitive, but it also has false positives. So again, you don't want to do that unless you're higher risk. Now, coming soon, and actually some places already have it, is what we call IV contrast mammography. And this is doing a mammogram where you get an IV. It's iodine-based contrast, but it's very quick and it doesn't require an hour. It's something that can be done in like 5 minutes. I actually think that's going to be a very good substitute for MRI. So we call this sort of poor man's MRI, but I think it will be actually a good woman's MRI. And it'll be a lot less expensive. And I think it's very clear. So that is just starting to work its way through the system. We're opening up our trial shortly. A lot of people pin their hopes on 3D mammography. This whole idea of tomosynthesis, that you could be looking at slices, just like a CT scan looks at multiple slices through the tissue. And people were hopeful that that better way of looking at the tissue was going to do the trick. And it does help some, it adds a little, but it doesn't add anywhere near as much as we'd hoped. So I think you'll see these kinds of changes in the future. And certainly because everyone's being told they have dense breast tissue, I mean, you got to say, okay, well, what should I do? And it's not clear to me if you've got that C, I wouldn't do anything necessarily different. If it's D, that's really when you want to be thinking about doing something different.
Mhm.
But actually, the advice I would give everybody is to join the wisdom study. Because we can actually look for other risk factors like, do you have an inherited genetic risk? And not only are we looking for 9 specific genes that might have an error, those are pretty uncommon, maybe 2-3% of the population have any one of these kind. But you inherit lots of other genes, a little bit different. Everyone's a little bit different from each other. And there are about 300-400 of these genes that by themselves don't mean very much, but together, polygenic gene risk, polygenic risk, we can identify people who are at higher risk and people who are at lower risk and average risk, and that can be very helpful. And so we're trying to test, can we do a better job of trying to understand who is, at risk for a slower growing tumor and who's at risk for a faster growing tumor. And partly because we don't just want to screen, we want to think about prevention. And I'll come back to this, as you can say, well, hey, if I was at risk for heart disease and I was known to have high cholesterol, or I had a family history of heart disease, someone would offer me a statin to reduce my cholesterol and sort of reduce my overall risk of getting a stroke or a heart attack. Why aren't we doing that in breast cancer? Well, we do have some of these tools. There are endocrine or hormone-based tools, tamoxifen, now we know that a very low dose of that can be very effective. It reduces your breast density, especially if you're under 50, and has very little side effects at these super low doses, but can cut your risk in half. And so that's just one example. And there are others that are working their way through the system. And as well, I've just recently come to know that there are some, there's companies that are developing, a drug that can basically attack scar tissue. And it looks like some of the same receptors might work here. So there may be other things coming on the market that can reduce risk. So I think for us in breast cancer, we want to be like the cardiologist. We want to understand what are the kinds of things that can increase your risk. And that's one of the cool things that we know about this polygenic many gene risk, is that there are these signatures that really predict that you're going to get a hormone driven tumor. So actually that's when, if you're in that 5% of the population that has that, we actually do have something that would be really very helpful to you in reducing your risk. So these are the things that we want to think about.
Laura, real quick, there's a question from Dolores. Dolores,
Sure,
do you
go ahead,
want to ask
Dolores.
your
I was just going to
question?
say, I was going to take a pause. Maybe I don't want to keep droning on and just see what kind of questions you guys have to direct the rest of the conversation.
Thank you for taking my question. I'm so happy you said the thing about ultrasound, we don't use it as a screening tool, because one of the things ultrasounds do not pick up are those calcifications
Right.
that are in dense breast. So that's one thing. And I'm so happy you explained about the 3D, because we waited for the 3D for so long. Machine. It's interesting to know the outcome is not as we expected it to be.
Yeah, that's one of the reasons why you have to run trials, because everyone really thinks we are just, we want to believe that new things are better. And sometimes they are, but sometimes they're not. Right?
Yes. Thank you.
Yeah, you're very welcome. Other questions or other things that people want, I'd be happy to direct that. I can go on and on forever, but that's not the point here.
I have a question. This is Coco Ye. I have dense breast. I've been told for years. I had DCIS about 5 years ago. And then I guess on Wisdom or somewhere I read that now when you get a mammogram, you'll be told how dense your breasts are. Well, I'm a Kaiser member, and I got a mammogram last August after I kind of had to do a little pushback in order to get it because I'm in my late 70s, and they thought, well, you don't really need one. Yeah, I do. Give me one. But it never said how dense my breasts were. So is that something I should be following up on? That when they give me my mammogram, that when they send me that letter, it should say on there how dense my breasts are.
It's actually part of that's sort of one of the requirements now for how you report it. So they need to tell you that.
Thank you.
One of the things that I always like to say is we want to do better than screen. We really want to be thinking about prevention. So someone who has risk factors, has had DCIS themselves, might have dense breast tissue, as you're older still, breast cancer can still be reasonable risk. So it really depends on how dense that tissue is and whether you can bring that down. So it's always, and it turns out that there's a cousin of tamoxifen called raloxifene, and the other name for it is Evista. And it turns out it's one of the drugs that we use to build bone. So if someone has osteoporosis or they have osteopenia and their bone health isn't that great, this is a drug that not only helps build your bone, but it also reduces your breast cancer risk as well. So that's another important thing to know, is know your bone health. And if your bone health, when you're older, it gets lower, that pick one of the medicines that actually reduces your risk of getting breast cancer. It can drop again, you're as close to 50%. So that's another thing to ask about. Okay.
Okay. Thank you.
So like if you had osteopenia and you had very dense breast tissue, perfect drug for you would be Evista or raloxifene.
So Laura, just to follow up on the FDA updates for the mammography regulations, just to give people a little more information in case you didn't see it in the news, it came out in a couple weeks ago, March 10th. So the FDA issued a national requirement for dense breast reporting, both to patients and also to their referring providers. And the guidance goes into effect, or compliance has to happen by September of 2024. But there's two
Well,
parts of it.
and that should not change in California, and
Right.
it shouldn't change in about 37 states, which already have dense breast notification laws. I object a little bit to the way this is, that it's dense or not dense, because that's, as I think you can see, it's not dense or not dense, right? If you go back to our ABCD version, right?
Mhm.
So it's like you're either CD or you're AB. But in fact, you really want to know if you're in D, because that's the one that really puts you at more risk. And as I said, about half the population has dense breast tissue. So half the population is going to be told that, and they're going to all be nervous. They're going to all go ask for an ultrasound or go ask for something, which is not necessarily in their best interests, right? So I say, like, good to know what your breast density is, but good to know what your comprehensive risk is. That's one of the reasons we're doing the wisdom study, is to help provide ways in which people can get that kind of information. And then help them understand, am I at high risk, and how often should I be screened, and can I go less, should I go more, and what tools should I be using? So we can go back to the FDA thing, but anyway, I'm just
Yeah.
saying
So I
that,
think
yeah.
as you mentioned, this is a limitation because it's grouped into two instead of the four categories. And I think in the wisdom study, we use the actual category to go into your risk assessment, because there is, different risks for each of the four categories. This is something that you can get off of your mammography report. And it's something we ask for in the wisdom study, whether it's for you to help us get that report, or we can ask your center directly for it. But you also have rights to get a copy of your actual radiology report, the mammography report, where the category will be listed, versus just the patient-facing letter that will give you dense or not dense. So, one area you can advocate for yourself is to try and get a copy of that mammogram report, the radiology report, where you can actually find the category that you're in.
Right. So I think that's actually, an excellent point. And, if you want to learn more about your risk, again, getting a comprehensive risk assessment that includes your breast density is super helpful. And that's part of, like, do we have all the answers? We don't, but that's one of the reasons why we want to study it. And why we want to encourage everybody to be part of a study like Wisdom, is so that we can continue to learn and improve and do a better job of figuring out who's at risk, but for what kind of a cancer, and what should we do about it? What can we do to reduce the risk? So those are the things that I think are super important.
I'll also note there was a question in the chat saying this person has been told they have dense breasts, but when she pulled up her mammogram report, it says BI-RADS 1. Just to note, there's actually 2 BI-RADS scores on a mammography report. One is indicating whether there's cancer or suspicion of cancer, and one is about your density. So if you do look at it, you'll want to try and look at the BI-RADS assessment for density.
Right. So BI-RADS 1 means they didn't find anything wrong. So there's 6 categories of BI-RADS for whether or not they found anything. So 1 means they didn't find anything. 2 means they're sort of scattered, benign looking things, like you can have cysts or various, little round things in your breast, and that's okay. Then 3, BI-RADS 3 means you have something extremely low risk, less than a 2% chance that it could be either invasive cancer or DCS. And then 4, which is sort of a big term, it's anywhere from a 3% risk to a 95% risk, meaning that there could be something that's abnormal that they need to do further investigation on, including maybe a biopsy. The vast majority of those will not turn out to be positive. So a lot of people panic when they get a recall, but most things turn out not to be cancer. And, we kind of encourage people to try and be a little more careful about what they're at risk for. instead of just recommending a biopsy always. And then BI-RADS 5, meaning it's almost assuredly a cancer. So if you get a BI-RADS 5, then it's cancer until proven otherwise. And so we would biopsy that for sure. And sometimes you'll see something called BI-RADS 6, which means they know that you have a cancer, and so they're doing a screening study on you, even though you know that you have a cancer. Now that's one of the reasons why the density is A, B, C, D. So it's not to be confused with the BI-RADS 1, 2, 3, 4, 5, or 6.
And
That's-
these categories listed up on the slide, this is the new guidelines that will be required, that all referring providers are told whether your density is A, B, C, or D. So that's what to look out for if you do get a copy of your mammogram report, or the A, B, C, D. And these words around fibroglandular density, heterogeneously dense, those are the words that will be associated with the ABCD.
And sometimes they don't say it, but the words in there will say that. That's the kind of stuff that they'll say.
Yeah.
I just wanted to bring up a couple other questions in the chat and make sure they were answered as well. So Tina, feel free to chime in if you have anything else, but Tina asked, is familial history more significant if family members had breast cancer before menopause?
So does it matter what age the women in your family were diagnosed in terms of a high risk or not?
Well, we do take that into account. So if the younger you are in your family member, the family members are, the more we worry about early risk for having an inherited mutation. So what we used to do is try and screen to see whether people should have or needed to have genetic testing to see if they inherit a mutation. But it turns out we're actually not very good at predicting that. And the best way to actually tell whether you've got a mutation is actually test for it. So that doesn't mean that we don't pay attention to family history too, because sometimes, I mean, we don't know about every mutation or everything that's wrong. But that's one of the reasons why in the wisdom study, now that the technology has gotten to be so you know, that genetic testing has now gotten to be really inexpensive and really very accurate. So it gives you the chance to be able to just ask directly whether you have it. And you can do that by spitting into a tube. They can analyze the DNA in your saliva, or you can do it by a blood test, but mostly we do it through spitting into a tube. You know, as I said, that these are in our study so far, we turned out that 60% of women who actually inherited a predisposition did not have family history. Now you can say, how could that be? Well, some people don't know their family history. Some people are adopted or are estranged from their family, or they come from a small family, or they come from a family with lots of boys, you know, where it's not very informative as to whether or not they have it. So those are just some few things to think about. Looking in the chat to see.
There's another question. Thank you so much, Dr. Esserman. Another question, are ultrasounds recommended for dense breasts?
Yeah, so we've been talking a lot about that. By itself, again, I don't really think that's a good idea, because it's not that, you know, really, if you've got high risk, you should have a contrast type mammography. And ultrasound is a great tool if something is wrong on the mammogram. It's perfect for looking for something, you know, if you can't find it so we try to organize biopsies using ultrasound, or, you know, if you see a mass on the mammogram, you can look with ultrasound to see if there's something that's associated there that you can see, and it's much, much easier to biopsy something under ultrasound than it is by mammography. So it's a great adjunct for mammograms, but it's not a substitute, and it's not a great screening tool. So this is another good question is, Can you change your breast density? Well, you can actually. Exercise can help you change it. Taking medicines like tamoxifen can reduce your breast density. Um, and there are medications that actually wind up reducing your breast density. These endocrine medicines or that are anti-estrogen in the breast and maybe, building an estrogen like in other parts, other body parts, they definitely reduce the breast density, and they reduce the chance that you would need a biopsy down the road because they makes it easier to see, and so that's one of the, that's one of the other advantages of taking something like tamoxifen. So if you have risk and you want to bring your own risk down, if someone has atypia or early onset DCIs, even that, we are running some trials for active surveillance in that setting where people don't have to have surgery if they don't need it, because really often DCIS in about 60-70% of cases is really an opportunity to reduce your risk. It's not cancer by itself. So
I think quick clarification to that. So it sounds like taking medication can help to change your breast density. I know in conversation last week, we were talking to a colleague about the idea that if you gained weight or if you stopped exercising and therefore, your body composition changed to be more fatty, would that change your breast density? And I think the answer is sort of, it changes part of your breast composition, but the main
not all of it.
area of the breast remains unchanged.
Yeah. So someone asked this question last week and in another forum and saying, well, if I gained a bunch of weight, wouldn't that make my breast be fatty? But I thought obesity was a risk factor. So how does this work? Well, if you have dense breast tissue, just gaining weight won't necessarily make the breasts fattier, and it won't really change it that much. So it doesn't quite work that way. And we are working with teams of people where we'll be able to automate or be able to read directly from a mammogram what type of density you have and how much risk there really is. And there are probably better tools coming to analyze that risk than the tools that we have today.
Great.
And that question is, can you feel it? You can feel some, but it's not perfect. Even if everything feels like a rock, then you know that you have extremely dense breast tissue. But most of the time it's something in between and you just can't tell, and you just need to come in and see us.
There's another question in the chat clarifying, is the average age of breast cancer really 33? And are the statistics 1 out of 8 women? So first, is the average age of breast cancer really 33?
No, the average age of breast cancer is not 33. The average age for getting breast cancer is someone in your 60s. That doesn't mean you can't get breast cancer when you're younger. So people can get breast cancer in their 20s. It's not very common, but you can. So it's really important that everybody know that screening is not perfect. And some cancers that are very fast growing can show up at any time in between a screen. So you should know your own breast tissue. You don't have to be obsessed with it. Just kind of know whether it's lumpy, bumpy or not. And you're just looking for change. If you feel like there's been a change and it doesn't kind of come and go with your periods or doesn't just come and go, then in fact, if you feel something new, you want to bring it to somebody's attention. And about 50% of women find their own breast cancers. So it's really important to know. And if you had a normal mammogram and then you develop a mass, don't ignore it because you had a normal mammogram. Make sure that you check it out and you explain. Just looking to see what else is in the chat here. Yeah, so that's 1 of 8. Okay.
I think another important point to make too, just going back to that, there's a whole spectrum of different risk factors. And even if you have, not dense breasts, but you have other risk factors, that's still important to pay attention to. And just pointing out that breast cancer or breast density is really just 1 out of many risk factors again, and that comprehensive risk assessment and knowledge of your other risk factors is still important. Breast density is not everything, just as family history isn't everything and genetics isn't everything. So better to have the whole picture and to make decisions off of that. Any other questions?
On any
like-
topic that you want to
Let's
talk.
see, there's one question. Do you know if the CDC's BCCS protocol to do both mammo and sonogram is still a requirement?
It should not be a requirement. The BCCC screening is mammography and not mammography and ultrasound, to my knowledge. Should not be.
Other questions? Feel free to raise your hand, or you can also speak up and ask those questions as well. And again, it doesn't have to just be about breast density, about breast cancer screening or prevention in general.
I have a question. If you could put density as a risk factor in, some kind of order with some of the other risk factors, where would it fall?
So a strong family history probably is the most important. If you had inherited a genetic mutation, that is by far the most significant. I think that women who have not ever had a pregnancy, that sort of drives risk, and that's probably more important than dense, your dense breast tissue. But again, there's a very modest increase in risk if you have BI-RADS C density. It's really only if you have that really high risk density. So I think it's important to think about it. And again, if you had inherited a sort of polygenic risk score, this other score where it showed that your density, despite your density, that you had a low risk score, you had low risk for getting breast cancer, that actually makes up for that breast density. Does that make sense? Is
Yep.
that Diane?
Yep, that helps. Thank you. It's just because we always talk about risk, but we don't often see how strong the risk factor is. I mean, it's a long list, but
It is a long list. And so, atypia is, if you've had a breast biopsy in the past, especially if it's atypia, that's a pretty strong driver. But it's when you combine atypia with something else, atypia and density, atypia and family history, or atypia and genetic mutation. These are things that together definitely make a difference. And the good news is a lot of people are afraid to take tamoxifen or raloxifene or exemestane or one of these things, but these medications really do drop your risk of getting hormone receptor positive disease. And we're getting much more sophisticated in our ability to predict that. About 80% of all cancer, 85% should be the things we move on to. So
I think one thing that was mentioned earlier was risk of breast cancer for women in their 30s. And for those people familiar with the Wisdom study, you'll know that at the current time, we enroll women between the ages of 40 and 74. But just to give a quick update and announcement that we are in the stages of changing the study protocol to include women starting at the age of 30. Right now, our enrollment is on pause and will be unpaused here in the next month to allow for upgrades to our risk models and our risk assessment, and also changes to our study protocol to include women in their 30s. As we've noted in this forum and in prior forums, we really want to identify those women at risk for those aggressive cancers, which are common or those are the types of cancers, if a woman is to get cancer in their 30s, it's generally more of the aggressive cancer. So our goal is to try and target and understand who's at risk for those aggressive cancers at younger ages and hopefully help to intervene earlier on.
So part of the reason we did this is because while inheriting a mutation that puts you at risk for breast cancer isn't very common, maybe it's 2-3% of the case, it is actually, for the people who have it, it really does increase their risk. And there are certain ones like BRCA2 or check too, where taking an endocrine therapy or, tamoxifen or raloxifene or one of these medicines can really reduce your chance of getting it. It's being forewarned is being forearmed, right? You can do something about it. And, what we found was, wow, we are really not, because we weren't looking at women under 40, we were ignoring the fact that if you had a mutation, your biggest risk is often in your 30s. So all those people who got breast cancer because they had inherited mutation, that was like a total loss for us. We missed that. We didn't help them at all. And so that's part of the reason. That was sort of what really motivated us to say, well, gosh, we're just kind of leaving, as long as now we know it's actually safe to do population-based genetic testing. If you're going to know about it, you should know about it when you're younger. And it's some people are afraid to get genetic testing. They think, gosh, I don't want to do that. Or what if something's wrong? Then they're going to make me do a bilateral prophylactic, mastectomy like Angelina Jolie, but that's actually not true. It's a very individual thing. And it really depends on your risk, your family history, what the breast density looks like, how easy it is to screen, and all those things. It can be so important. It's such a personal decision. And there's more than one way to go about it. So that's why we're in favor of knowing this information and sort of getting it out to the public and make sure that we can do a good job with it.
All right. Any other questions? I know there's a couple more specific questions around sending data to the study, and we can follow up on that one. In general, again, the density information that you will get with this new, or if you've already gotten it on your reports with the FDA guidance, it only tells you whether you are in the bucket of dense or not dense. And so we encourage you to advocate for yourself and get a copy of your mammogram report and look for that BI-RADS density assessment of A, B, C, or D to understand if you're in one of the highest density bucket of D, and may want to consider, along with your other risk factors, additional screening options. So
Kim, yes, Kim, did you want to make any comments or add anything?
No, I don't think I had anything to add. I appreciated the tips for how to advocate for yourself, because I think ultimately, as I've said several times before, what you all are doing with the wisdom study is trying to push the way we do things in the clinical space. And that always comes with resistance. And often it's the patients who have to lead the way. So really just appreciate the support for the advocacy that some of these women are going to have to do to really get, what may be more cutting edge rather than cookie cutter approaches to breast cancer screening.
If it weren't for women and women being interested in being in clinical studies, we'd still be doing radical mastectomies today. They're the ones that wanted something less aggressive. They're the ones that have wanted the testing of the tumors to figure out who needs chemo and who doesn't, or the lumpectomy versus mastectomy studies, every study that's changed, that's how we changed our approach to breast cancer. But it's really from women demanding better. And I always say, we've got to do better than just say, oh, you've got to age 40, so you should get a mammogram, or it's 50. And how do I know if I should do it every year or every other year? Well, that's the whole idea, is that we're trying to give you a better, more sophisticated, personalized recommendation. But as we learn, we want to be able to update it. There's hidden information in the mammograms, for example. And lots of people are talking about artificial intelligence. Well, no surprise, it's come to digital images as well. And they look to see what pattern is there, and they can really spread it from people at very low risk to people at a lot higher risk. And so we're looking to try and figure out how to integrate that to the inherited. We're looking to understand how that fits in with your comprehensive risk, and, not just say, oh, you're 40, you need a mammogram, or you're 60 and you need a mammogram. But it's like, well, how much risk do you have? What kind of tumor are you at risk for? How can we do the best we can for you, in particular if you're high risk. Well, here's a screening strategy for you, and here's also a preventive strategy. Remember, the reason why women don't die of heart disease more than they die of cancer is because people have participated in these opportunities, to lower their risk. And that's why statins are so common, and they drop your chance of dying of heart disease or stroke by 30-40%. It's amazing. So we're going to try and get there for breast cancer, because I would bet that everybody on this phone wants to avoid the risk that they've been told that they need, screening and so on. Yeah.
And going back to the original celebration of Women's History Month, I think, as you mentioned, women who are participating in trials, women who are advocating for themselves, everyone's part of the movement to improve healthcare and making history. So appreciate everyone joining today and being part of the conversation. We would love for you to fill out our evaluation that's in the chat. You can see it's already popped, or it will be popping up on the screen for you if it hasn't already. Our next community forum, again, we have these the last Monday of every month from 4 to 5 p.m. Pacific time. Since you registered, it means that you're registered now for all future forums, and please do share the link and pass this along. We will end the poll here in just a second, but we will take these responses. It looks like a lot of people have some great feedback on what they'd like to see next, and we'll be able to tailor some of the next upcoming forums to the topics that you tell us you're most interested in learning, and we will get some of the experts in the field, some of the clinicians and researchers and advocates who are working on these topics to participate and talk to you and with you about your questions and how these topics may pertain to your breast screening and or breast cancer experience. So I'm going to go ahead and end the poll. It looks like the most popular topic is around toxic and chemical exposures, followed by wisdom participant experiences and polygenic risk scores. So we will save this and make sure that we will focus our next few months on these topics. And also, as other news comes out, other data comes out, we always know that there are stories that come out in the news that prompt new topics to come up. Please let us know. You can always email us. You can always let us know if there's another topic that appears that you'd like to learn a little bit more about. So with that, thank you so much, everyone, for joining. We really appreciate your participation today.
Thanks, everybody.
Yeah, we hope you have a great rest of your evening. And again, please do let us know if you have any other topics or questions. We are happy to answer things offline. Feel free to email us at info@wisdomstudy.org. All right. Thanks so much.
Everybody.